Making our way back to our preferred locations. Very good. I believe the proverbial bells have been rung, doors are being closed, toilets have been flushed. We are ready for our next set of conversations. Okay, it is my high honor to bring you now Mark Fendrick. Mark's a friend. He's also a leading advocate and basically coined the term value-based insurance design. And that value-based insurance design idea has really taken off. So much so, even in Virginia, we're now implementing it through our state employees program. It's going to be an integral part of our state innovation model. Mark directs the Center for Value-Based Design at the University of Michigan and still actively practices internal medicine. His research focuses on the impact of clinical payment and consumer engagement initiatives on access to care, quality, and healthcare costs. He's one of the few people who understands both clinical and economic issues and has a great style of fostering collaboration across government agencies, health plans, societies, and everything else. But most importantly, Mark is going to answer my fourth question. What the heck do we do about all this now? He's got a concrete solution, and I'm proud to welcome him to the stage. Mark Fendrick.
Thank you so much. Hi, everybody. It's a great honor and pleasure to be here and to follow Len, Indu, and James. What a perfect setup for me to talk about what I've been working on for the past 20 years. Since I knew Len would be wearing his cowboy boots, I decided to honor my father-in-law, who worked for the Colorado Public Health Commission, by wearing his lucky charm here. And since I think I'm the only one wearing it, I hope it's lucky for me, maybe not for you guys. It's been a great pleasure for me as a practicing clinician and someone who's been almost surprisingly dragged into the state and national health policy discussion about an idea I want to discuss with you that may help us transform this healthcare system from volume to value. I know that's an alliterative, overused phrase, but it may be something that we can move forward on after these really exciting 3 days. I will also tell you that my kids, and maybe most of you who are actively tweeting, will never know what it is to sound like a broken record. But some of you do. David Ballard is here, Len. I mean, I've been talking about this issue of value-based insurance design before it was even called value-based insurance design. And over the next 27 minutes or so, I'd like to impart the concept upon you and, more importantly, hear from you about where you think it might fit into some of the really exciting and lofty efforts nationally that we heard about from Indu and here in Colorado from James. So I still remain quite honored and humbled to be a practicing clinician and do devote a fair bit of my time to primary care. Most of my patients until recently were uninsured. Now many of them are insured because of aspects of the Affordable Care Act. And I try to start every one of my remarks to let people know that why we're in the healthcare business is to make individuals and populations healthier. And as you see from the slide, there are innovations to prevent and treat disease have led to impressive reductions in morbidity and mortality. The fascinating part about this, and I often look for the exit before I say this, is that myself and the hundreds of thousands of clinical colleagues that I work with in population and in hospital-based medicine, we did not learn or go to medical school, nursing school, nurse practitioner school, et cetera, to learn how to save you money. And what I find as I've traveled to 49 states talking about these issues, and if you have any colleagues in North Dakota who are willing to invite me during the 2 weeks of good weather, I'll happy to go there. But regardless of where I go, and regardless of these improvements in the health of individuals and populations, the discussion is always about cost. It's always about bending the trend. And while it didn't surprise me to hear Len quote the great Reba McEntire, and our previous speakers talk about theologians and Mark Twain, I like to quote the great health policy researcher Woody Allen, who said the best way to reduce expenditures is death. Thanks for the chuckles there. So we're not in that business, although when I moved to Michigan 23 years ago, Jack Kevorkian was actually performing euthanasia on 60 Minutes, but thankfully that has changed. But I think this idea of how much we spend, bend the trend is something we need to get away from. Because if I were to ask any of you, this very sophisticated audience, should we be buying in healthcare? The report's out today, we've surpassed $3 trillion. Big news. Healthcare cost growth going up to over 5%. You'll all see that when you get back to your offices. Regardless of this, if I asked you what should we be buying, we're not buying enough of those immunizations, screenings, management of chronic disease, end-of-life care. So again, I look for the exit. Again, when I tell key decision makers like you, we have to spend more, not less. But we have to spend more in a different way. That if I was able to bring out my maize and blue foam finger from the University of Michigan, I think the key takeaway for me to you is that we have to change this conversation from how much we spend to how well we spend. Because sometimes it's worth spending more. And many, many of the things that we recommend through the quality initiatives that James mentioned actually will increase healthcare costs in the short term instead of lowering them. Most of the things that I'm incented to do through pay-for-performance programs and new quality initiatives don't save money. They make people healthier, they're good expenditures, and I think that's something we should really think hard about, because if we continue to go down this save money rabbit hole, I really do believe we will be harming people net as opposed to helping them. So we had this great discussion from James about how the provider side, the supply side is so rapidly changing, and that's so sophisticated. These issues are well above my pay grade. My focus of my research career has always been on the consumer, the client, my patient. So not the employer, not the third-party administrator, not the state of Colorado. And I've spent a lot of time about what my patients actually pay out of pocket to see how much healthier they could become. And if you think about cost sharing, you think about what individuals pay in terms of premiums and co-payments and deductibles, you'd like to think that we would put financial barriers in front of those things that people shouldn't buy. And in fact, we would keep financial incentives in place and cost sharing low for the things that I literally beg my patients to do. But with rare exception, I think I could speak quite frankly that Colorado is a leading state around the country, but most Americans are in health plans that have this archaic one-size-fits-all benefit design. And what I mean by that is that you pay the same out of pocket for every doctor that you see, whether it be a cardiologist after a heart attack or a dermatologist for mild acne that I could barely see. You pay the same out of pocket for every diagnostic test, one that I am benchmarked on to do more of, one I'm benchmarked on to do less of. Same out of pocket expenditure for consumers. And I think the easiest way to pitch the problem is that within a tier of a drug formulary, my patients pay the same out of pocket for drugs that potentially life-saving, diabetes, cancer, depression, heart disease, smoking cessation, as drugs that make toenail fungus go away or their hair grow back. Right? I don't understand why the incentive for the patient tends to be based more on the price of things as opposed to how much healthier they become. So as Len knows, I've been talking about this for quite some time, and people were really focusing on payment reform and alternative payment models and other types of things. And then lo and behold, in the past 5 years or so, consumer cost sharing, even for those who are well insured, starting rising rapidly. And I became obsessed with $50 co-payments for insulin, statins to lower blood pressure, branded antidepressants. And now what keeps me up at night, except the altitude here, but what keeps me up at night are deductibles. And I'd like to hear a little bit more about what's going on in terms of deductibles, meaning that your insurance plan does not kick in until you pay 100% of the amount of that thing. That I have permission to tell you about a patient of mine who I saw on January 2nd. I helped her through a navigator get her first health insurance ever through our expansion of Medicaid in Michigan. She ended up with a consumer-directed high-deductible health plan. And it turns out her deductible was $4,000, and I knew for many years her disposable income for everything, rent, gas, food, was about $5,000. Her visit to see me, her primary care doctor, was deductible exempt. And we were talking about her diabetes and her control, and she said, you know, Dr. Fendrick, I'm so proud to have this insurance card, but my insulin, my blood pressure medicines, and my cholesterol medicines are not covered before the deductible. My eye exam and foot exam that you beg me to do aren't covered before the deductible. And that hemoglobin A1C test, I think that Len mentioned, the one that tells us how well we're doing, is also not covered before the deductible. So if that's not bad enough, she said to me, I'll see you next January, or I'll see you when I'm in the hospital. So these are the types of stories about, you know, sure, people are insured now, but I'm not sure how covered they are. And when we talk about Patient Protection and Affordable Care Act, I hope we can move to both patient protection, that meaning coverage, as well as affordability. And as we heard earlier, a lot of these things are remarkably interchanged. So my mother said, I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it. Now, there might be some people in this room who are willing to get up during our discussion and defend this concept of skin in the game. I am a huge supporter of personal responsibility and patient accountability. I do not believe that skin in the game and engagement, which Indu talked about, and Len as well, absolutely always has to mean that people pay more for stuff. And I'm finding it very frustrating, and I use that as a soft adjective, to see that nationally, less so Colorado, but in some segments here, that this skin in the game is actually meaning to make people pay more for everything. And as I said, I want people to pay more for services, but I want them to pay for the services that they don't need. I want them to pay for the services for which the evidence shows it's not going to make them healthier. So, like all of your mothers, my mother was right. Michael Chernew, a colleague of Len and mine, I've been working with Mike for many years. We had the great fortune to do several taxpayer-funded studies to show that my mother was right. As you make people pay more for drugs, for doctor visits, for mammograms, for flu shots, they buy less of them. And as we are applauding the historic low rates of people who claim to have no insurance, there is this new, very important term, and I was talking to a number of people during the break about this, that being underinsured, that people actually have insurance cards, as I mentioned, like my patient, but that insurance basically provides for catastrophic events, which is a very important aspect. But if we're really trying to move this whole system to a value-based one, it's truly remarkable to see that while fewer people are having trouble with medical bills overall, the fastest growing group of folks who are now being tracked down for unpaid medical bills are those who have insurance, as opposed to previously were the ones who don't. So the great part about this conference, I think we're going to be talking about a number of really key initiatives, and I was really happy to see Indu finish with her presentation with listen, partner, and participate. If it's okay with you, I'd like to add one of my own to your three, which is alignment. I think the whole key, integration, comprehensiveness, I think alignment is really important in the fact that we all know that consumers do not have the necessary information to make informed decisions. And there are really well-done studies that clinicians make really poor decisions regarding their healthcare choices as well. And while we have worked very closely with the pay-for-performance movement, as well as the transparency movement to provide information on cost and quality, I stand here before you to say I'm still very, very nervous, and I really do believe that even when we have these situations in place, if the consumer is not appropriately incented, it does not ensure appropriate care delivery. And when I think about all the comments mentioned earlier today and wherever I go, talk about consumer engagement, better engaged patients, all these other types of things, I ask you a very simple question. Do you think that Coloradans would be more likely to be engaged and incented if they have to pay less to do something, as opposed to the current trend where they're being asked to pay more for those exact same things. And that's the lens from which I look. So I feel very strongly that consumer engagement solutions are necessary to better allocate the enormity of the dollars we spend in Colorado and elsewhere based on how healthy individuals and populations will become, not the price and profitability. And I'm really happy to see that the provider side, through issues that James had mentioned, are really starting to walk the walk, just not talk the talk through alternative payment models such as bundled payments and global capitation and other types of things. But I really believe that the consumer side is not only lagging behind, and I'll get to this later, I actually believe that they're going in the wrong direction. Some for good motivated reasons, some for unintended consequences. So looking at the demographics of this audience, I bet about half of you, maybe a third, saw the movie with Leonardo DiCaprio called Inception. And I see some nods. But those who didn't, you don't have to raise your hand. It's a movie about putting someone else's idea into your head and having it think your idea. So this is my attempt to do an Inception on you. All right? So thanks for the great idea called clinical nuance. I really believe that the potential solution, given the multiplicity of stakeholders and people in the room today, is this idea of clinical nuance. And what I mean by clinical nuance is medical services differ in the health benefit produced. Some drugs within the tier of the formulary, more important than others. We could argue that later at the bar, which ones, but I think you'd agree with that. Some diagnostic tests, more important in terms of health than others. And some doctor visits, more important than others. And I love to tell this story. I got to go to talk to about 1,000 AARP members in South Florida, talking about the idea of clinical nuance. And most of you might know that after card playing, visiting the doctor is the #2 hobby in South Florida. So a typical Medicare beneficiary in South Florida will have over 8 physicians on their record. And this woman came out of the audience afterward talking about clinical nuance that she had to buy in. She walked out of the crowd up to the podium just like this. She was about 4'10", so I jumped off the podium and we looked eye to eye. And she said, "Dr. Fendrick, I have 10 doctors." I said, "That doesn't surprise me at all." She said, "I have a Christmas party for them every year." I said, "That doesn't surprise me either. That's terrific. I wish I were one of your doctors." She said, "I like them all the same," which led me to nervousness. It was the first person ever to challenge me on the idea of clinical nuance. And she came up to me, whispered in my ears, and she said, "I know full well that some of these doctors are making me healthier and some of them aren't. And I will do whatever I can to help you support the clinical nuance idea." The fact that no one has actually come up and said, this first part of clinical nuance is something I can't get on board with. We may disagree what is the high-value drug and the low-value drug, but I can't believe that if I showed most of you non-clinicians a list of drugs that Coloradans are spending $4 for or $45 for or now 20% for, that you would argue that they're all the same. And I'm sure later in the breakouts we're going to start talking about specialty drugs, which is making a lot of you very nervous. That in most plans in the United States of America, people, first off, don't pay flat copays. They pay a percentage of these drugs, some of them tens of thousands, now some of them hundreds of thousands of dollars. They pay the same coinsurance for drugs that cure cancer 90% of the time as drugs that never cure a case. Now, I know there are a lot of really important business leaders in this room, and I would like to ask you, what management class did you learn that in? The fact that I see incentives for my patients to buy low-cost things that don't make them healthier and lead often situations to people foreclosing on their homes or taking out second mortgages to pay for services that we are benchmarked on as clinicians, as medical groups, and health systems such as James. So clinical nuance is very key. That you have to look now at all you're doing in terms of payment reform and benefit design, that the things that you want to buy more of, and turn to the great groups in the room saying, these are the high value things, these are the benchmark things, these are the things that the American Diabetes Association says we should do more of. And now many of you have heard of the initiative called Choosing Wisely, run by the American Board of Internal Medicine Foundation, Consumers Union that publishes consumers reports, over 50 medical societies now publicly saying certain services that we should be doing less of because the evidence is not as strong as others. So the clinical nuance thing, I believe, is the ultimate solution to allow this conversation from how much to how well. Now, this gets a little tricky, and I'm sure this will come up. Oh, what are the good things? What are the bad things? And it's been very interesting to me in talking about this. I often frequently ask audiences, tell me things that we should buy more of. Tell me things we should buy less of. Most of the things that people want to buy more of tend to be preventive services. Colon cancer screening, shots, counseling for obesity and depression, for which rates are systematically low for uptake, even in situations when prices to the patient are zero. So that suggests that we have some low-value services, and people will frequently throw out their low-value services, MRIs, other high-cost imaging, coronary stents, other types of things. But my answer when people ask me is that my 3 favorite high-value services are colonoscopy, coronary stents, and back surgery. My 3 favorite low-value services are colonoscopy, coronary stents, and back surgery. That's because the value of a clinical intervention depends on who gets it, who provides it, and where it's provided. And I think these are some of the key tenets moving forward. And as the person who coined the term the Katie Couric effect and did the study to show that Katie's Today Show colonoscopy impacted the public health of Americans more than $1 billion of federal basic science funding in the disease, I use colorectal cancer screening as an example of this second type of clinical nuance. So colorectal cancer screening, if you're a first-degree relative of a colorectal cancer survivor, you should be paid to get screened. If you're 50, you should get screened for free, and that's the law of the land. I'll touch on that very briefly. And if you're 29 years old without a family history who are motivated to get screened because of the Today Show, you should be fined $50 for getting that thing. And make sure your mother takes that appointment, right? Because we got to have to use the clinical nuance moving forward. So how do we implement clinical nuance? We call it value-based insurance design. People call it value-based design, value-based benefit design. Let's think about an idea where we set consumer cost sharing based on how much healthier you would become, not the price. What a neat idea. Reduce or eliminate financial barriers to high-value clinical services or providers, now health systems, ACOs, et cetera. And it's amazing when I always look at this slide, it's over 12 years ago when the Wall Street Journal published about VBID for the first time. You know, for those of you who know academics who are measured on we publish or perish, right? Well, we published and still perished until the national media started picking up on this idea. And maybe more importantly, that several very large, very influential self-insured employers said, this sounds like something we should get behind and do. And it was Pitney Bowes and Safeway and Marriott and Dell and now hundreds of public and private payers who've put this into place. And I think many organizations in Colorado, including Engaged Public and the Colorado Business Group on Health, that's really kind of taken the VBID idea and started nurturing it here in this state. So VBID has expanded from the easier low-lying fruit to pick the drugs that are high value to things across the board of clinical care, including something that makes James either excited or nervous, that many plans now are saying, I'm going to make it less expensive for you to go see this doctor, this MRI facility, this surgical team. And we're very pleased to see that it's clinical quality and cost that are being used in these incentives as opposed to just going to the lowest cost place. And I think what's really neat about this, and it's very unusual, and Len is a fellow academic trying to look and making all these parts of the triple aim and all these constituents happy, value-based insurance design thus far has really been a win-win-win. I had the honor to testify in front of the US Congress where someone told me that I've done the most to slow the adoption of my own idea, in the fact that I would not make the claim that without inclusions of carrots for good stuff and sticks for low-value services, that VBID would not lower healthcare cost net, because most of the things that we encourage our patients to do actually increase healthcare costs. They're cost-effective, not cost-saving. So consumers certainly win because their health improves and their overall out-of-pocket costs go down. And in the days of now more and more premiums cost sharing, that's very, very positive in terms of public relations from the Human Resources Department. The payers are now, as I said, getting into this idea of promoting efficiency and wasteful spending. And last, the doctors, as they're being moved to alternative payment models, are actually seeing quite clearly that it aligns with the incentives that many of these alternative payment models are putting in place. What's unique about this very quickly is in healthcare, there are very few ideas that have broad multi-stakeholder and bipartisan political support. The fact that we have the country's largest union, the U.S. Chamber of Commerce on board, we have the American Hospital Association and Families USA and the health plans and the pharma manufacturers have been very exciting for us moving forward. And I'm going to just quickly go through some policy aspects of this because, you know, I don't see patients full time. I travel around a lot. My mother thinks I work for the CIA. I had the good fortune to actually write part of the Affordable Care Act, Section 2713, which mandates zero-cost primary preventive services, which led to this broad definition of value-based insurance design that allows you the ability to change cost sharing for providers, treatments, and services. We have really neat initiatives to expand value-based insurance design to Medicare Advantage, and to the organizers of this meeting to have this on the 50th birthday of Medicare. Maybe you'll sing that tomorrow morning when the 50th birthday actually occurs. We've had the good fortune to acknowledge the rising cost-related non-adherence for Medicare beneficiaries, so much so that cost-related non-adherence has risen higher to than before Medicare Part D was put in place for drugs. There was an aspect of the original law in 1965 that did not allow us to put VBID principles in place. So what did I do? My first trip to Washington since my 5th grade field trip, I helped actually write a bill to allow value-based insurance design principles in Medicare Advantage. We are very excited about this. This bill has passed the House of Representatives with strong bipartisan support and is being currently considered by the Senate, as long as CMS likely to put a request for proposals to health plans, many in the room, to allow VBID in Medicare. Last point I'd like to make in my closing 5 minutes is what's happening in the commercial marketplace, and I alluded to this briefly, is the growth of health savings accounts, qualified high deductible health plans. And as I said, I love this idea of consumer accountability and patient responsibility. What I don't like is the fact that as deductibles grow, we don't allow exempt from the deductible the services that James's pay-for-performance programs are now asking actively primary care and specialty doctors to do more of. You all know, have seen from Commonwealth Fund, Kaiser Family Foundation, Families USA, we are being asked to pay more and more. And more of you are not only doing this with the advent of the Cadillac tax on the horizon, thinking about ways to avoid that 40% excise tax and figuring out the only way to do that is to cost share to your beneficiaries. The good news is that the IRS, when they put these regulations forward in 2004 and 5, did allow this safe harbor for certain preventive services that are now mandated through the ACA to be zero cost sharing. The bad news is in Colorado and elsewhere, over 85% of spending in healthcare is not on preventive services, it's on chronic diseases. And because the IRS guidance, and I know the guy who wrote it who said this is what happens when you ask tax lawyers to write health policy, they put in a clause that said that any services used to treat existing illness, injury, or conditions, this is almost my entire practice, must be exempt, cannot be exempt from the deductibles. So as we now study more and more, as people are asked to pay more out of pocket, they use less of those care services, they result in poorer health outcomes, and in some cases, overall, increased costs, which seems to make no sense. So what we have proposed is something called the High Value Health Plan, which requires either an act of Congress or the act of the very well-known august health services board called the Internal Revenue Service to change the deductible exempt idea, to allow you to create plans that keep deductibles on the things deductibles should be on, the things you shouldn't be buying, but allow the safe harbor for those high-value services for which the physicians and other clinicians in James's programs are being incented to do more often, such as a diabetic eye exam or a hemoglobin A1C for a diabetic. We have modeled out this high-value health plan and found it through an independent analysis from the University of Minnesota. I think Len knows Steve Parente and Roger Feldman. They love the idea of a plan with a high deductible for services you shouldn't buy, with protection for the services that we beg our patients to do. It allows your premium to go down from a PPO or an HMO, maybe avoid the Cadillac tax, but also allows those people like my patient to actually get coverage for the premiums they're paying, and it's estimated that 40 million enrollees would uptake this type of plan if it were to become available. So we call it Smarter Deductibles and Better Value, and you could learn a lot about this initiative through the vbidcenter.org website. I'm going to close with an oversimplification of, I think, what we try to do in this panel, which is to try to help move volume to value. All the action, all the sophistication, all the expertise, and all the money, and certainly the nicer suits, as James shows you, are on the supply side initiatives. I mean, and I'm not going to disagree. I think that this is where the complexity is. This is where the controversy lies. But the good news is, with the private sector and now Secretary Burwell, we are really moving away from fee-for-service to some type of value-based payment. I applaud the supply side for doing that because I thought that was the big challenge. I call supply side peanut butter. I have worked my entire career on the consumer side or the demand side, which I call jelly. Right? Isn't it interesting that I, as a primary care provider, are incented to do certain things? The fastest growing type of health plan in the United States of America does not cover my patients at all to do those same things. I turn to you to think about the first time your mother, father, grandmother, sister, brother put peanut butter, payment reform, jelly, consumer engagement together, right? The way we can make this happen is through clinical nuance, right? And if we have clinical nuance payment reform, which is moving rapidly, as James told you, with consumer engagement, clinically nuanced benefit design tied with the remarkable advances that Indu talked about to allow that education to happen, it will lead, I believe, to the attainment of the triple aim. And as Len might know, I was really not a big fan of anything that actually could bring about population health satisfaction and cost reduction. But given the large amount of underuse of high-value services and the extraordinarily overspending on services that don't make Americans any healthier, it'll take your leadership to buy more of the good stuff and less of the bad stuff. And in closing, since you challenged me to use quotes, James, in the words of Dan Quayle, if we don't succeed, then we will fail. Thank you very much. Please follow us on Twitter, all you active Twitters, and look forward to the conversation.